Okay, I think it must be Paul getting back in again. Hang on.
Apologies for that. Let's
Oh,
see.
that's good.
Let's see if we.
You could also email it to me and I could try controlling it from my end, if that helps.
Neil, the presentation is close to 200 megabytes.
Ah, okay. My Wi-Fi might better cope.
That's not going to work. Let me see. This is very embarrassing because I did open my presentation, but it doesn't recognize the presentation, and I have no clue why that is.
You could try screen share, maybe.
Yeah, that's what I'm doing. But normally, when I do screen share, I should be able to see the different windows on my computer, and I don't see what I want.
Oh, then you have to go. Then you get a few options. You get your entire screen and window Chrome tab.
Yeah, but it keeps opening a lecture that I was giving to the medical students previously.
Oh, okay.
And I have no idea why it's doing that and why. Are you still seeing my screen share now?
I'm seeing your screen share, which is a watermark, like a watermark of the world map.
Yeah. But that's not what I want. I want a different one. And why would I not be able to do that? I'm going to stop my screen share, Neil.
Whereabouts are you physically located at the moment?
Paul, that's Steph asking where you are because she might be able to help you.
Yeah, where are you physically located at the moment?
At the Royal Bird Hospital.
Whereabouts? Because I might be able to, because I'm in the MRF, I might be able to duck over and see what's
level 3 north building, and I'm close to the office of the head of department.
That doesn't actually help me that much.
Okay. Look,
the other thing you could do is, if this is really just not working, is you could duck over to the MRF and we can plug you in over here.
No, well, what I'll do, I have an older version of my presentation on my desktop, and I might just do that. It's not what I wanted to do, but let's go ahead. That will be smooth and hopefully painless. Okay, so let me do that and log in again.
Okay.
Teams has not been very friendly here in a hospital environment. Never has been. I do lots of meetings. My preference is for Zoom. I'm going to close this and come right back from my office PC. Is that okay?
Okay. Thanks, Paul. Sorry, everyone. Any other? Do people want to throw me any other ideas for talks in the future? I always hate this when this happens when I'm presenting. I remember I was presenting at an international meeting and all of my pictures in every slide disappeared. All I had was the text. Horrible feeling.
Can you see?
Yeah, we can see something, Paul.
And can you tell me, Neil, what you see?
Raw Perth with a black swan.
Yep, that's
Yep.
good.
All yours.
Okay, I will go into presentation mode. And I don't have to worry about people waiting in the lobby, right?
Yep, I was sorted out. You just go ahead. All done.
Okay.
Yep.
So once again, many thanks to Professor Boudeville and many thanks to all of you students, medical students of year 4. We will be talking about imaging in acute stroke. You've heard who I am. English is not my native language. I struggle a little bit with English. I'll try to do my best and make up for the lost time. So just some thoughts to start with. What I don't like is to use a kind of cookbook approach to medicine. I strongly believe that medicine and the future of your thinking should be based in physiology, anatomy, and fundamental knowledge. And I'd like to give you a few thoughts to start with. One is that in another adult patient, our brain represents about 1/50th of the total weight of the body. It's about 1.4 kilos in a 75 kilo individual. But it receives about 1/6 of the cardiac output, and it consumes about 1/5 of the oxygen. What that tells you is that the brain is a metabolically very active organ. And all those of you who have ever done an internship or even a short time spent in a department of nuclear medicine know that on a PET scan, the brain shows up very bright because there is so much consumption of oxygen. Now, the cerebral blood flow, known as the CBF, is defined as the rate of delivery of blood and nutrients to the capillary bed, which is the main parameter to measure cerebral perfusion. And I think when you talk about stroke, you should always remember that heart and brain are two sides of the same medal, two sides of the same coin, if you want. And I would like to start with simply focusing your ideas on cerebral blood flow, CBF. How can you calculate that? And we're going to do that in a Socratic way, looking at a number of questions. What is the cardiac stroke volume? What's the average heart frequency? What is cardiac output? What percentage of cardiac output goes to the brain? In what units is CBF expressed? And what is the weight of the brain? And then what is the overall cerebral blood flow? In my world, overall CBF is something that any medical practitioner should be familiar with. So let's start with the pump. The heart is basically a pump that has a stroke volume of about 70 mLs in an untrained individual. Let's assume that this heart is beating at 70 beats per minute. That means that every minute there's about 5 liters of blood that is pumped by the heart. Now, where does that blood go? Where do those 5 liters per minute go? Well, you can see a number of organs listed here. Our focus this evening is on the brain, which receives about 15% of 5 liters. So that is about 750 milliliters of blood. If we know nothing about the brain, if we consider it as a black box, we know that there's an inflow of 750 mLs and then a venous outflow of 750 mLs. And what happens inside, we're going to leave that blank for the time being. Now, the brain weighs about 1.35 kilograms, depending on your constitution, your sex, your age, etc. So if that 1.35 kilograms receives 750 mLs of flow per minute, you can express the flow into the black box as milliliters per minute per 100 grams of tissue. and that gives you a normal cerebral blood flow of approximately 50 mLs per minute per 100 grams of brain tissue. So that is a number I think that you should try to remember. It's about the same flow rate as the myocardial muscle gets, both very highly metabolically active. Now, in the brain, you may remember from anatomy that there are two kinds of tissue, the gray matter, which has a somewhat higher flow because it's more metabolically active, and the white matter, which is somewhat less metabolically active and receives about 30 to 45 mLs, but the average is about 50 mLs per minute. Cerebral perfusion pressure is defined as the difference between the mean arterial pressure and the intracranial pressure that is expressed here. And in a normal person, cerebral perfusion pressure ranges between 50 to 150 millimeters of mercury. Now, if that pressure is too low, the brain becomes ischemic. If that pressure is too high, the brain becomes hyperemic and you get a brain that becomes engorged with blood. In a pressure passive system, if you plot in the horizontal axis mean pressure versus flow in the vertical axis, there would be a kind of linear relationship between pressure and flow. Now, the brain is not a pressure passive system. The brain has autoregulation, which is a mechanism that maintains blood flow to the brain. Unlike other organs, cerebral blood flow is to a large extent independent of arterial pressure, and that is represented here. In the brain, the blood flow is indicated by the orange dotted line. And as you can see, it is, I don't know, can you see my mouse when I point to something?
No, we can't.
You don't, okay. So you can see that the cerebral blood flow is more or less independent in that range between 50 to 150 millimeters of mercury. And how is that achieved? It's achieved by changing the diameter of the vessels. At a low perfusion pressure, the blood vessels in the brain are relatively dilated. As you increase the perfusion pressure, the arterioles vasoconstrict, and that is known as autoregulation. If you have a failure of this process, you call that under a number of names, a hypertensive crisis. In patients who are chronically hypertensive, this function or this curve is shifted to the right, as you can see here. So they live in a constant status of vasoconstriction, and they are more amenable to all kinds of bad things, including stroke. Good. Now, talking about acute stroke, that's what I wanted to start with. And I wanted to start with the pathophysiology of brain infarction. This is a cartoon from the New England Journal of Medicine a few years ago, simply indicating that if you have a small penetrating vessel that becomes blocked by an embolic infarct, that becomes blocked by an embolus, basically you have an area around that vessel that infarcts almost immediately, and which is surrounded by a halo of sort of intermediate blue-purple, which is called the penumbra. And the theory is that the small initial infarct, which is called the core, eventually will evolve into a much larger infarct. So the penumbra will progressively infarct. We've established, we learned that normal cerebral blood flow is about 50, 60 mLs per 100 grams of tissue per minute. The brain, in those circumstances, derives its energy supply from oxidative phosphorylation. As that blood flow decreases, you extract more oxygen, you extract more glucose, but there comes a point where that metabolic pathway, oxidative phosphorylation, stops. And at that point, what fails is the membrane pump. so the sodium-potassium pump, you have an influx of sodium and calcium and other electrolytes. The cells swell. This is usually known as cytotoxic edema, although semantically it would be more correct to call it ionic edema. And I was making those changes in my other presentation. I was also changing the spelling of edema to the British edema with OE. And that is something that happens in minutes. And this is what we can pick up with an MRI scanner within minutes after a major stroke. At the same time that the membrane pumps fail in the neurons, they also fail in the endothelium, which leads to a breakdown of the blood-brain barrier with an influx of water from the vascular compartment into the intercellular compartment, and that causes vasogenic edema. And that is the hypodensity, the low attenuation area that you pick up on a CT, but that may take a few hours and in some cases even longer to actually pick up. Now, I will skip this. This is the outcome to avoid. This is a slide that I brought from Antwerp. A patient with a massive right MCA stroke, massive with hemorrhagic transformation, and that is the corresponding brain cutting that we were doing every week to correlate the imaging findings with the brain pathology findings. Now, in imaging, when you talk about imaging in stroke, there are 4 P's that are important. It's kind of 4 acronyms, and those P's refer to the brain parenchyma, the pipes, the perfusion, and the penumbra, and we're going to look into that relatively quickly. I know that you are Year 4 medical students, so I'm assuming that you are familiar with most of these concepts. So parenchyma, the most important steps are to rule out hemorrhage and assess early signs of stroke. In the pipes, you want to assess the extracranial circulation. You want to look for what is known as a large vessel occlusion, and you want to look for the intracranial circulation for evidence of an intravascular thrombus. Perfusion assesses your cerebral blood volume, flow, mean transit time, and capillary permeability. And in assessing the penumbra, you are trying to assess the tissue at risk of dying if ischemia continues without recanalization. So parenchyma, you know, and I know that there are basically 2 kinds of strokes. The first kind is an hemorrhagic stroke, which represents 15–20% of all acute stroke syndromes, typically subdivided into intracerebral hemorrhage. And you see here an example of what is known as a putaminal hemorrhage or subarachnoid hemorrhage. So putaminal hemorrhage, which typically occurs in hypertension, and there are a few other locations. So the striatocapsular region, putamen external capsule, it accounts for about 2/3 of these. The thalamus, the pons, and the cerebellum are relatively less frequent locations for hypertensive intracranial hemorrhage. One thing that we were always teaching our registrars to look for is to look for a high density area within the aqueduct. As you can see here, there is a small focus of high density that is blood in the Sylvian aqueduct, and patients who have that are at risk of developing hydrocephalus at a later stage. The second type of intracranial hemorrhage is subarachnoid hemorrhage. And here you see a 39-year-old man with a thunderclap headache, with an aneurysm at the anterior communicating artery. And I had a beautiful video that works on my Mac, but that doesn't run, unfortunately, on the PC. So you will have to take my word for it. This is a 4D CT angiogram where you can see the aneurysm beautifully depicted in a non-invasive way. If you want to detect hemorrhage, CT has always been the gold standard, but you should be aware that CT is not perfect. Here's a patient with a stroke in the left cerebellum, This is known as the pica distribution, posterior inferior cerebellar artery. And it looks to me and to you like it's simply a low attenuation area of non-hemorrhagic stroke. But in this patient, MRI was done on day 2, and it shows that there are, in fact, multiple micro and even macro hemorrhages within that stroke. So remember that MRI is much more sensitive in picking up blood degradation products than a CT scan. And a CT scan, notably in the posterior fossa with this beam hardening artifact, may be suboptimal for seeing that. The second issue about the parenchyma is that you want to look for signs of acute stroke. So we aim to understand the topography and the extent of a cerebral infarction. And we can do that with either CT or MRI. And there's just a few literature data, and as you can see, this is all mainly old literature showing that CT is of limited use in revealing early signs of infarction. There's a few tricks of the trade that you can learn, and I will go through them. One trick, and probably the most useful in a middle cerebral artery stroke, is the hyperdense string sign. You can see here on the left side, the M1 segment of the MCA is spontaneously hyperdense, and this is the area that I'm talking about, and this is the next day where you see a large area of infarcted brain tissue. A second sign that takes a little bit more training in your eye is called the obscuration of the lentiform nucleus. If you look at this patient, the right image, you see that on the left side, there, the lentiform nucleus is nicely outlined by the anterior and posterior limb of the internal capsule. If you look at the right side, that gray white matter definition is gone. I'm sorry, and I know that you're not seeing my pointer, but just please take a look and compare the basal ganglia on the right image. Compare the basal ganglia between right and left, and where the gray-white matter differentiation is gone, that is where you suspect a stroke. But you need some experience and you need to be awake to make that diagnosis. A third trick is the so-called insular ribbon sign. In this patient, you recognize that there's a high density, a hyperattenuation in the left MCA M1 segment. And when you look in the insular region, you see that on the left side, there's a low density area surrounding the insula. This is called the insular ribbon sign. And it's always by comparing right and left that you make these diagnoses. But these signs are very, very subtle. You need to have experience, you need to be trained. And here at Royal Perth, where we have the neuro meeting every Wednesday morning, there's often long discussions based on CT. Is there something there? Is it nothing? Can we window it differently? How big is it? So it's not easy. So there are several limitations that CT has. I'm not going to read through my slide, but my key point is that non-contrast CT has a limited role in predicting brain infarction. The key role of CT is to detect hemorrhage and other stroke mimics, tumor, for example, that could be the cause of a neurologic deficit. So MRI in stroke is more sensitive, and the biggest difference has been made by a sequence that is known as diffusion-weighted magnetic resonance imaging. That was first described in New York in the late 1990s, but really became a workhorse 15 years ago, maybe 20 years ago. And here you see a patient with a right MCA, middle cerebral artery stroke, evolving from 5 hours to 9 hours, 36 hours to 5 days. And you can see the evolution of the signal intensity. And interestingly, this signal intensity change is apparent already a few hours after the stroke and even less than 1 hour after the stroke. So just to illustrate the power of this technique, Here is a patient. I show you a reasonable quality T2 and a reasonable quality flare, and I challenge you to tell me where is the stroke. And I think you will not be able to see anything. But when I add the diffusion-weighted scans, you see that there's a focal area of increased signal intensity involving the posterior limb of the internal capsule, and that area is dark on the apparent diffusion coefficient maps, meaning that there is diffusion restriction, and this corresponds to a right anterior choroidal artery infarct. That's a typical vascular distribution pattern. You cannot pick it up on the non-diffusion sequences, but it is very obvious on the diffusion-weighted sequences, like a lamp glowing in the darkness. Same thing here, elderly patient, flare and T2, and these are the diffusion-weighted images, high signal on the B1000 diffusion-weighted image, low signal on the ADC map, acute stroke in the right MCA distribution, hyperacute right MCA infarct. Many of our patients are elderly individuals with pre-existing white matter disease. You can see that here illustrated in this patient. This is white matter that is not looking very happy. But what the diffusion-weighted image does is it shows you the acute infarct, which is on the left side, close to the posterior limb of the internal capsule, and there is some microhemorrhage associated with it, as you can see on the SWI slide on the right. So differentiating old versus new infarcts is what we can do with this technique. So why does this work? Well, the idea is that in normal brain tissue, water molecules flow freely, and there's a rapid exchange of constituents from the intra to the extracellular environment and vice versa. When brain cells lose their sodium-potassium pumps, they swell and they suffer something that is known as cytotoxic edema. Literature also speaks about ionic edema. In radiology, those two terms are usually used interchangeably, and I was going to adapt that actually on my slide, but was not able to. So second key point, diffusion-weighted imaging is vastly superior to CT in detecting the infarct core in the early stages of brain infarction. Next item is pipes. Pipes, the blood vessels. Evaluation of the pipes can be done both with MR and with CT. And I do apologize, this was a very nice video showing that there is occlusion of the left MCA, and there's a small infarct involving the medial thalamus. I was going to run the animation, and I can do it perfectly on my Mac, but unfortunately not on my desktop computer. This, however, should work. This is the equivalent of looking for a large vessel occlusion with CT. This is a 4D CT angiography, and you will immediately recognize that there's a complete occlusion of the internal carotid artery on the left side. You can see it again here. So there's heavy calcification in the carotid bulb, but a complete occlusion of the blood vessel distal to the bulb with some microinfarcts in the internal watershed, as you can see on the diffusion-weighted images displayed on the right side. So the third key point is, typically because stroke patients first undergo a non-contrast CT, in most places, and certainly in Australia, it is efficient to acquire a CT angiogram immediately afterwards. But be aware that MR angiography is also reliable, though maybe slightly less than CT angiography. Perfusion and penumbra. We've talked about the pathophysiology of a stroke. In red, you see the situation immediately after a stroke where the tissue distal to the occlusion becomes infarcted, and that is known as the infarct core. In green, you see the penumbra that tends to grow over the ensuing 6 hours to 24 hours. And the longer you wait to reestablish the blood flow, the greater this penumbra becomes, and in this case will eventually involve the entire MCA territory, except for that region that is supplied by collaterals coming from the anterior cerebral artery in this case. Different way of presenting the same thing. This is a slide given to me by my friend Professor David Michaelis from the University of Toronto. So you can see the infarct core, which is dead brain, and there is nothing that we currently can do to prevent that from happening. It is almost immediate cell death following occlusion. But this area is surrounded by a halo of the penumbra, oligemia, and a bigger area of what is sometimes known as benign oligemia. And all of the energy that we currently invest in stroke treatment is to prevent that core from becoming larger and growing into the size of the penumbra. The perfusion in acute stroke is a way of differentiating the core from the penumbra. A patient with a right MCA stroke, you can see the diffusion restriction as an area of increased signal intensity on the DWI image and reduced diffusion on the ADC map. And now look at the MR perfusion we did in this patient. And I show you immediately the parametric maps. So you see that the core infarct in red, which corresponds to the diffusion abnormality, is an area that has both reduced cerebral blood flow and cerebral blood volume. The penumbra, which is much larger, indicated in green-yellow, is an area that has reduced blood flow, but still normal blood volume. And the question is, how does that work? How can you have reduced flow, but still normal volume? And the answer is because the vessels in that region vasodilate. They are maximally vasodilated, so they try to keep up some volume of blood in the brain, but eventually after a few hours that stops and those cells will inexorably die. Can do the same thing with CT. I don't want to go into the technique, but you see here that there's a non-filling of the right MCA compared to the other side. And you can see here on the non-contrast CT upon admission, which is not very convincing. These are the parametric maps, and this is the situation 24 hours later. So there are two techniques to do perfusion, CT and MR. And the main purpose of perfusion imaging is to establish the difference between the core infarct and the penumbra. If there is a large penumbra, that patient will be amenable to endovascular therapy, and we can expect good success. If the core infarct is the same size as the penumbra, that means that you are dealing with an established stroke and there is not much we're going to be able to do. So a lot of research has been devoted to these imaging techniques, CT perfusion, for identification and quantification of early infarct versus penumbra. But there are some neuroimaging methods which are effective, but others are not. And CT perfusion is notably unreliable. It provides a low signal, high noise, and large uncertainty. And even in the Perth region, we see that the perfusion that is performed on a GE scanner is completely different from what you see on a Toshiba scanner or a Philips scanner. There is no standardization in this. And of course, with CT, there's the radiation issue. I show you this image. It's a little bit dated, but just to let you know what radiation can do to a patient. This is from a Japanese group showing a 53-year-old woman who had a band of hair loss that was caused by the radiation effects after undergoing 4 CT perfusions and 2 CTA studies. So there is that effect. The thing is not about imaging. The thing is about, are we able to help the patient? And I'm going to show you side by side 2 different patients showing what can be done and what cannot be done. So this is a 38-year-old woman admitted with a left hemiparesis, and I show you the non-contrast CT and the CT perfusion upon admission. Non-contrast CT is kind of iffy, doesn't show much, right? The CT perfusion shows you that there is decreased perfusion in the right hemisphere corresponding to the right MCA territory. We did in this patient a CT angiography showing occlusion of the right internal carotid. This is a case from Antwerp, and in Antwerp we had ample MRI availability. So the patient was immediately placed on the MRI, confirming that there is no flow in the right internal carotid. The white dots that you can see in the right image reflect flow in the left ICA and in the basilar trunk. There's no flow in the right internal carotid. The patient was taken to, this is the MR, showing no diffusion restriction. So we're in a very, very early stage of the infarct. The patient was taken to the endovascular suite. You can see that there is like a meniscus sign. There's a complete occlusion of the internal carotid artery. And on the right side, you see the status after reperfusion. So this all went as quickly as possible. Beautiful results. From a plumbing point of view, everything is perfect. Reconstitution of the blood flow, everything beautiful. And that is the follow-up MRI after 3 days. And what does that mean? That's exactly what I've told you. The core of the infarct is irretrievably lost. But what we did here is we prevented the penumbra from becoming an infarct by a rapid intervention. So this is about as good as it gets. And, you know, this is a complete infarct of the lenticular nucleus, but the patient was neurologically intact. Contrast this with this patient, a 66-year-old woman with a left hemiparesis. Here on the CT scan, you can already surmise that there's a decreased gray-white matter interface, which is confirmed on the perfusion maps, which is confirmed on the CT angiography. You can see the stump of the M1 segment of the right middle cerebral artery. By the way, in Antwerp, we had this 3D analysis software available on all workstations, so anybody could do that, and that was much quicker than anything. You could just, quick and dirty way of looking at the vasculature. This patient was taken to the endovascular suite, but unfortunately, mechanical thrombectomy was not successful. Thrombolysis was tried, thrombectomy was not successful. It happens because one embolic stroke is different from a different one. We liaised with our vascular surgeon who took the patient immediately to theater. You can see here the dissection, the skull is open. That's the clot in the right MCA that he's taking out now. And this was the CT angiography after the surgical intervention. So from a plumbing point of view, that is a success. But unfortunately, this was the situation on a follow-up scan showing that there's a quite large area in the right opercular frontal region that we were not able to save. So key point 5 is we do try very hard to help these patients, but there's a lot more to treatment of acute stroke than opening up the pipes. And close multidisciplinary collaboration is essential in managing a stroke patient. Final point, CT versus MR. In most of the civilized world, that is a discussion that is very active. Unfortunately, it is not a discussion that's active in Perth because we don't have access to MR. So we only have access to CT in stroke. And that is, I think, unfortunate, and that is not where the future is going to go. So for your information, side by side, the different pros and cons of the two techniques. So CT, usually you start with a CT to exclude hemorrhage, and you could then do in the same sitting a CT angio and a CT perfusion. So it's a one-stop shop. With MR, theoretically, you would need 2 stops. So many people are now saying that that is not necessary. But the big strength of MR is that you can detect ischemic brain very early, very quickly. You can show it within minutes, certainly within half an hour of a stroke, you can see the diffusion restriction. You can see the penumbra with both techniques. It's a different kind of enhancement. You can cover the entire brain with MR, also now today with most CT scans. The contrast is different, but CT still has radiation. And at Mass General Hospital, where I did my fellowship a number of years ago, but Mass General Hospital has been one of the major centers in the world to advocate use of MRI in early stroke. And you see that in the flow chart here. Diffusion-weighted imaging is the one and only technique that will show you ischemic brain tissue. We've had long discussions here in Perth, but you may remember that famous quote that was attributed to Henry Ford, who said, if I would have asked customers what they wanted, they would have told me they needed a faster horse. That seems to be the discussions that we're having in Perth. If you ask doctors here what they would want, they'd say we would need better CTs and more CTs. But of course, that is not the answer. The answer is eventually going to be we need MRI in the emergency department, and we need to be able to access that immediately. And that is where the future is going. Final thoughts, and I apologize for being somewhat long-winded. So CT and MR provide complementary information, and you have to understand what are the pros and cons of each technique. For hemorrhage, CT, non-contrast CT remains the frontline method, but MRI with T2 star or susceptibility-weighted imaging is actually more sensitive to hemorrhagic transformation. For showing vessel occlusion, currently CTA has a little advantage over MR angiography. That is level 1, class 1 evidence. For detection of the infarct core, diffusion MRI is the preferred technique, and that is absolutely level 1, class 1 evidence. There's no discussion about that. And for identification of the penumbra, you need perfusion imaging. That has a lot of intellectual appeal, but the evidence currently remains inefficient. And that, Professor Boudeville, dear students, that was what I had to tell you. I'll be happy to take any questions, and I apologize for the technical difficulties at the beginning, which are purely due to my stupidity and of course also to Teams. Thank you.
Thanks, Paul. Fantastic talk. I'm a Mac user too, so I refuse to believe it's a Mac issue. So very, very clear talk. I love the 4 Ps and the clarity in your specific highlighted items. While I'm waiting for some of the students to put any questions in, I was a bit confused as to, like, there does seem to be a flourish of MRIs in Perth to me as a simple kidney specialist, but there should still be more, and if there should still be more, why is it purely a cost thing, or they don't believe in the technology?
Well, this is it's a very interesting, Neil. You should remember that I've been here only a little bit over 2 years. I would say that any answer I could possibly give you would be politically incorrect, but it seems that in Perth, decisions on what equipment to buy and where to install that equipment are very often not made by the people using that equipment or the people needing that equipment. So to the best of my knowledge, there is not a single hospital now that has an MRI in the emergency department. I was in a meeting earlier today. I've been successful in getting a mobile baby MRI to come to Royal Perth, and that will arrive in June. So that will be a unit that we could potentially use in the ED. Don't know yet how good it is, but it has diffusion-weighted imaging, and it could potentially be used to pick up early signs of stroke in the emergency department, or it could be used in an ICU environment because the MR goes to the patient bedside as opposed to the patient having to come to the MRI.
Wow, amazing. But you clearly believe that MR is the preferred technology for acute strokes.
I do believe that, but I've been talking to the NISWA, the Neuro Imaging and Interventional Service of Western Australia, and the current belief of the NISWA people is that they have to work with CT, not because they like it so much, but because this is the reality on the ground and they have to deal with that reality. I think within 5 years, within 10 years, I don't know, MR seems to be undergoing a technical revolution with more low field scanners, and I do personally believe that the future of imaging is going to be point of care, that we will need to be able to bring the imaging equipment to the patient rather than transporting a patient through the corridors of hospital to come to a heavy piece of equipment that is fixed in location.
Okay. I've got a question from one of the students who's asked, could you please run through the different types of MRI views and what you'd use each one for besides DWI?
Okay, so as you know, you have to think of an MRI as a symphony orchestra, right? So in a symphony orchestra, you have a lot of instruments, and each instrument has a score to play, and all of these scores together make hopefully a beautiful piece of music. So the scores in the MRI are called the pulse sequences. In a stroke patient, we would typically start with a diffusion-weighted image that picks up cytotoxic/ionic edema. And that diffusion-weighted image, to give you an idea, takes about 50 seconds on a modern MRI sequence. But of course, you have to install the patient. Then the other sequences we would use would be a FLAIR, fluid attenuated inversion recovery, and or a T2 weighted sequence. What those sequences do is they pick up water in the brain, so they're going to pick up vasogenic edema. We would typically use a T1 weighted sequence for general anatomy to look for brain swelling or displacement of cortical gyri or midline shift. We would use a susceptibility weighted technique, T2 star or susceptibility weighted imaging to pick up hemorrhage. And then we would do an MR angiography at the circle of Willis, including the skull base arteries to look for a large vessel occlusion, either outside the skull, in the skull base, or in one or more of the major branches of the circle of Willis. Hope that answers the question.
Thanks a lot. There's another question here, non-stroke related question, Paul, if that's okay. One of the students was asking about what imaging you'd suggest for, or there was a question really about pearls of wisdom regarding atypical migraines, as they've seen a few this year.
Okay. So atypical migraine, typically on MR, the main reason for doing imaging in patients with atypical migraine would be to exclude something else, something bad, a tumor or a vascular malformation or anything. The findings in atypical migraine tend to be relatively non-specific. There's a whole range of findings, but if that person would want to talk to me, I will be happy to provide some more information.
Okay, perfect. I'll just go to the last question, if that's okay. So someone is obviously inspired by your talk, Paul, and wants to know about a pathway into neuroradiology. And any tips as to how they acquire this through their junior medical years?
Okay. So the you have to know that radiology tends to be competitive here. Typically, we would prefer candidates who have a number of clinical years behind them. Clinical knowledge is important. Knowledge of neuroanatomy or a previous master's or background in the neurosciences is obviously very useful for us. But that being said, there are multiple ways to skin a cat. There are multiple entry points, but it all starts with getting accepted to do radiology. So we strongly believe that people do radiology first, and then during their 4 years of registrarship, we see how well they do with exams and how things are going. And then if they express an interest, they could do a fellowship in neuroradiology, but admittedly, that would not be my decision. You would have to talk to Dr. Konfaturos or any of his colleagues in the NISWA group. And I think we are very fortunate as unfortunate as we are in Perth by not having sufficient access to MR, the more fortunate we are in Perth by having access to great diagnostic and interventional neuroradiologists in NISWA. NISWA is actually quite famous across the world. It's one of the great success stories of this city. And all of you may know that there are many vertical silos in Perth between hospital and hospital groups and universities, and there are more people that are not working together than people working together. NISWA has been very successful, and as far as I know, one of the very few organizations that has cut across those boundaries and be very, very successful to provide amazing care to all kinds of neuro patients in Perth.
Yeah, totally agree. The revolutionised stroke care, certainly amongst patients in Perth. So I might just finish off there. I don't like going over time at all, Paul, but thank you very much for a wonderful talk. And I hope you don't mind. I've recorded it. I don't know if I actually asked you. I've recorded it for the students who were unable to attend today. Okay.
Okay.
Thanks a lot. See you later, everyone. Have a good weekend.
Thank you. Bye-bye.
Thanks.